I'll write these down for you. We have a 15-year-old, okay, heart rate's 150. Let's say her blood pressure is 72/34. Her respiratory rate is 30. Her temperature is 38.0. And her SATs are 92. Okay. She's had no urine outputs for, most of the morning. And she has, mom tells you that the girl reported that she was having some diarrhea starting last night, all right? And when you do a circulatory exam on her, her upper extremity pulses are 2+, but her lower extremity pulses are 1+. She's rather cool, slightly mottled. Okay. All right. That's your history. That's your physical exam. All right. Let's even pretend that we don't have any objective data except for her vital signs. Okay. She just got in. You're working in in the ER or wherever, and you don't even have any labs back. Okay. Once again, you work. You can make an assessment you make it with whatever information you have at the time. Okay. In a perfect world, you would have all the available information. All right. But we don't live there. At least I haven't found it yet. And think about all the times you get called to the floor. All right, and you don't know the patient's history. You have no idea what meds they're on. Okay, you don't know what their morning labs were. Okay, but you are approaching the patient and pretty much 90% based on just that patient's physical exam. All right, you're making a clinical assessment. Okay, so sometimes the more emergent the situation, the less information you actually have, and it's not necessarily a problem, because that means you need to focus more on even the basics. The ABCs is what we're talking about, okay? All right, so let's look at our 15-year-old. Let's look at what we have. You agree that we're tachycardic? Okay, so we're tachycardic. We're hypotensive, okay? We're a bit tachypnic, okay? We have a bit of a fever, and who knows? We don't know. Maybe it was 40 before. All right, maybe if we keep watching it, it'll be 40 in an hour, okay? We don't know that, but right now she's got a low-grade fever. She has, her SATs aren't awful, all right? And that could certainly be affected by her perfusion, all right? She has no urine output. She has notable losses. In other words, we have a history of fluid loss, and we have where, okay, how. In other words, she wasn't bleeding to death, okay, she was having diarrhea. All right, and we have evidence of decreased perfusion, okay? So now we want to take all that information and make it in one nice little precise phrase, all right, that the minute I relate that to someone else, okay, we're both going to hopefully come to the same conclusion of our patient's clinical status and the intervention that needs to be done, okay? So what I would say is this is a 15-year-old, all right, with hypotension and decreased perfusion, all right, presumably from intravascular volume depletion, all right? And that in one little phrase, all right, should help me communicate with all of my medical caretakers about what is currently going on with this, what is my patient's current physiologic status, all right? And if we're accurate and appropriate with that, then that's going to determine our next intervention. So what do we do? What intervention do we perform with someone who we believe has inadequate perfusion and decreased intravascular volume? Yeah, I mean, we give them fluid, yeah? Okay, so once again, Our clinical assessment determines our appropriate intervention, okay? So that's clinical assessment, all right? It's not a diagnosis, all right? Not a diagnosis. Do we know why she's having diarrhea? No. Okay, maybe she wanted to lose weight and she was, taking a bunch of, laxatives, okay? Maybe she has enterovirus, all right? And, she's having profuse, diarrhea from enterovirus. She could have cholera. I mean, we don't really care necessarily what the diagnosis is. We just care what our patient's current physiologic status is, and that determines it substantiates an appropriate response or intervention, okay?